Good evening, everybody. Good evening, Lauren.
Evening. Hi, how are you?
I'm good, good. And we have our
Yeah.
fancy backgrounds this evening.
Yes, we've got new backgrounds.
Yeah,
We're matching. Twinning tonight.
twinning tonight.
Have you
Welcome,
not enjoying the
everybody.
sunshine?
Oh my God, it's gorgeous. So nice.
Doesn't it make
Yeah.
such a difference
Oh my God, I've
to
been
how
out
you
walking.
feel?
Yeah,
Like when you wake
definitely.
up and the sun is coming in, it just makes such a difference compared to like the dark and dreary mornings. You're a
Definitely.
bit further south than me, but
Yeah.
it's been very dark here, very dark and grey in Scotland.
So really looking forward to this evening, Lauren, and giving everybody a chance to come in. You're very welcome, everybody. How are you all today? Maybe
The
put in
chat
the
is
chat where
open.
you are. Let's see where everybody is. I've got Ireland, Scotland, the UK,
Oh, people are writing.
London,
Oh,
London.
Leeds, Blackburn, London, Winchester, Dublin, Sunderland. I was going too fast. Gloucester. We've got people everywhere. We've probably got someone from every corner of the UK. Stirling, yeah, Team Scotland, Glasgow, Kent,
Oh,
Wakefield. Oh, Northern Ireland, yay.
there's quite a lot of Northern Ireland actually.
Yeah, Team Northern Ireland. Galway, Ipswich, Edinburgh, loads of people.
Loads. Very busy this evening.
Yeah,
Well,
everywhere.
you're all very welcome. Oh, I thought that said New York then.
Yeah. That would be a very exotic location for. Oh, someone's in Libya. Hmm, there you
Hello,
go.
Libya.
That is, yeah. I didn't think there was going to be anyone outside the UK and Ireland. Hello.
Well, we always get Australia, but they watch back on
Yes, that's
demand.
true.
In Australia at the moment, yes,
Oh,
yes, yes.
Austria. I think it says Austria.
Oh, was it Austria? Okay. So we are 1932, so we're going to make a start. Just to let everybody know that there will be a QR code at the end. I'll try and do a little reminder halfway through as well if anybody comes in a little bit later. But the QR code will put it up. You answer the questions, please tick all the boxes, and then your CPD certificate will be sent to you in an email. If there are any queries, I'm going to put an email address into the chat, and you can just email me in the next couple of days if you don't receive that for any reason. If you have to leave the webinar and come back in again and you've missed some of it, you can watch it back on demand and you can answer the questions that way to get your certificate. Thank you very much. I'm delighted to have Lauren Long here this evening doing Examining Excellence. And I know Lauren has a slide coming up, but Lauren really has been at the coalface of dental therapy, implementing this into practice. She is a director of over how many dental therapists and hygienists, Lauren? It changes, I know.
I think it's 22 now. I think on last count. Like,
So, yeah, well placed to do this with us. I know you do a lot of mentoring and training within the practice. You have therapy model led, and I'm sure you're going to speak a little bit about that as well. Lauren also runs a course called Restore, and she'll tell you a little bit about that at the end as well. So let's get started, and I'll hand over to you, Lauren, and please tell a little bit about your journey as well. Thank you.
perfect. Thank you so much, Siobhan. So, thank you to everyone for joining us on a very sunny day. Thank you for coming in from the sunshine to watch a webinar. I mean, some of you might be doing some alfresco watching. Who knows if it's nice enough? But tonight we are going to talk about a topic that we have had loads of requests for. I am seeing posts and messages on the forums. I'm getting messages from people as well asking about doing exams. So this is something that I have done in practice for 14 years now, I think it is. So I have worked in a therapy-led practice for 14 years. Us therapists carry out all the exams. So this is one of my favorite topics to talk about. So I've been a dental therapist for 18 years this year, which makes me sound like really, really old. I've also done a couple of postgrad diplomas in restorative and aesthetic dentistry, dental education coaching and mentoring as well. As Siobhan mentioned, I'm therapist clinical director for Pain Free Dentistry Group, based mostly in Scotland in the north of England. And dental therapy lead for NSK Ikigai, and I'm also secretary of the BADT. So what are we going to talk about tonight? So, the aim of tonight is to try and strengthen dental therapists and dental hygienists' confidence and competence in delivering thorough, evidence-based clinical exams and assessments within their professional scope of practice. Okay, and we'll talk a bit about scope of practice in a bit. We're going to talk about the components of a comprehensive clinical exam. We're going to do a structured assessment framework to support accurate diagnosis and risk assessment of your patients. We're going to talk about evidence-based treatment plan creation. We're going to talk about your documentation and your reasoning to support patient-centered care as well. Okay. So when we think about our dental records, it's a wonder that we get everything written down when you see all these things that make up patient records. So, we have things like personal information, medical history, examination notes, even things like study models, so physical things like study models, any video recordings, diagnosis, treatment planning, things that you don't want in your patient records, like medical legal reports, any kind of litigation correspondence with solicitors, loads and loads of things that make up patient records. So we're going to talk about how to break this down and how to make it easy to do in day-to-day practice for your patients. Okay, so why are records important? They are obviously an essential component of your clinical care for your patients. They enable continuing care by providing accurate information. So, if you leave a practice, if someone else sees your patient on the next visit, the idea is that your records should be really clear so that that person can come in, work out exactly what happened in the last appointment, work out maybe even where you are within a treatment plan and what was to happen next. They're considered to be an accurate account of the facts. I'm sure we all remember when we were at uni, you're always told if you haven't written it down, it didn't happen. Whether it happened or not written down, from a medical legal point of view, it didn't happen. So we've got to write everything down. And it's how we do that in a concise and clear way and without, writing too much and with writing enough as well. And they also, as I say, act as evidence in medical legal situations. So, if a patient makes a complaint, God forbid, goes to the GDC, something like that, goes to solicitor, if you've written everything down and you've noted exactly what you've done and you have, behaved correctly, then, you shouldn't have an issue and it will get you out of many a sticky situation, even with just a kind of surface level complaint if you've noted everything down. Okay, so where do we come in as dental therapists and dental hygienists? So the GDC scope of practice, as you will know, has not changed, but they've reworded it. So they've tried to make it a bit more clear and concise. So I have basically gone through this new version from November 2025, and this is what it says about our part in doing patient examinations. So as a dental therapist or a hygienist, you can carry out clinical exams within your scope and competence, and you can also refer on to other healthcare professionals if necessary. You can diagnose and care plan within your scope and competence. You can also appropriately prescribe taking and interpreting radiographs within scope, and we'll talk a little bit more about that later on. As a hygienist, the last point about exams on your scope of practice says that you can identify soft and hard tissue abnormalities and conditions, provide treatment when it's in scope, and make appropriate referrals when it's out of scope. As a therapist, the difference is that you can identify and you can also treat hard tissue diseases, and you can identify soft tissue abnormalities and again refer when outside of your scope. Okay, so examinations are relevant to everyone. That's the point I'm trying to make. We see questions quite a lot of, can a hygienist carry out an examination? Can a therapist carry out an examination? The answer is yes, but within your scope of practice and within your competence. So, for example, as a hygienist, identifying hard tissues, so teeth, restorations, things like that, you can identify things that are abnormal. So they've really stressed this in the new scope of practice. You're identifying things that are abnormal and then referring onward to someone else to diagnose and to treatment plan that care for your patient. Okay, so we'll talk about how you can do that. So things to note, if you are carrying out examinations under direct access, you should notify your indemnity company. Some of them will care, some of them will not. Some of them, don't really even want you to notify them. If you're doing this, they'll just say, oh, it's fine, we don't charge any extra. But I would always say notify them anyway, because some of them will want to add it to your policy in writing to say that you are indemnified for that. So depending on who you're with, just double check with them what their stance on that is. Check your undergraduate course syllabus. So this is where I was speaking about radiographs. Depending on when you qualified. So I qualified in 2008. We did not do prescribing and interpreting radiographs back then. There's not really, a question we get quite a lot is when is the cutoff point? What year did therapists and hygienists start to be able to prescribe and interpret radiographs? There isn't really a concrete answer to that, and because different unis started doing it at different times. So you would have to go back, check your course syllabus. I mean, probably the safest thing is if you're not sure and if you don't feel confident doing it, do a course. So Jimmy McDissy does a great course. I have done his where he takes you through everything. There's like new online modules and things since I did it as well. Really easy to do. You can do it on demand as and when. And then that means that you are able to do, full direct access and taking radiographs as well. And we'll mention a few reasons later on of why radiographs are so important for an examination. If you haven't completed your exemptions training, you will need a PGD or a PSD for your local anaesthetic or any fluoride varnishes that are prescription-only medicines as well. And you must inform your patient that you are a dental hygienist or a dental therapist and the limitations to your scope of practice when you carry out their exams. So something along the lines of I always think of Ian Dunn as Mrs. Jones, so I'm going to go with Mr. McDonald because we're in Scotland. So, hi, Mr. McDonald. My name is Lauren. I'm going to do your checkup today. I'm a dental therapist. I can provide you with X, Y, Z treatment. If there is anything that is outside my remit, or that I need further assessment from a dentist or another colleague with, I will refer you on to that person. Something like that. And just note that in your notes as well. Patient informed that I am a dental therapist and the limitations of my scope of practice, and the onward referral is available if necessary. Okay. So we're going to go through the full patient examination journey. So we will start with the pre-assessment. So pre-assessment meaning anything that you do basically before you look in your patient's mouth. So you can build quite a good picture about your patient, before they even open their mouth. Sometimes even before they sit in your chair, they will have filled things in beforehand. Even just chatting to them, you'll get information from them that might be relevant to the treatment plan, diagnosis, and the examination that you're going to carry out. Okay. So medical history, obviously, we're all taking medical histories at every visit. New forms should be completed or updated at every visit for every patient. This is obviously to prevent medical emergencies. So, for example, if your patient is allergic to something that you have in your surgery, you're going to know about that and you're not going to use it. Avoid any contraindications. So, for example, air polishing, things like that. If your patient has a lung disease, you're not going to use that. Anything that you might see in their mouth that is an oral manifestation of any medications. And obviously, with our, we still talk about the new perio guidelines. However, it's now been, what, 9 years, something like that, since the 2017 classification. We are talking about medical risk factors as well as part of our diagnosis. So we're noting that down for our patients. We want our medical history form to be dated and signed and obviously discussed with your patient if need be. If you think there are things that they have not written down or, you think there's something you need to probe them a bit further about, then do that to get as much information from them as possible. Their dental history. So we want to know, do they have any issues currently when they come into the surgery? Usually they will tell you. Some people take a bit more questioning. You want to know the history of that complaint, and we'll talk in a second about how to take a really, really good complaint history. Any other issues that they have, previous dental treatment. So if they're new to your practice, you might want to know how long has it been since you have seen a dental professional? What did you have carried out last time you were there? Any underlying dental issues that they may have. Long-term dental needs. So things like, patient may tell you that they have had a lot of fill-ins in the past and that their dentist prescribes them high fluoride toothpaste, so like Durafat, something like that. And whether they're a regular attender obviously helps us to gauge what we might see when they open their mouth as well. And of course, their oral hygiene habits, we want to know about those before we start any sort of assessment as well. So presenting complaints. So like I say, most patients will tell you about this as soon as they come into your surgery. But you want to know, are they having any pain? Have they got any swelling? So this is where we talk about pre-assessment is, if your patient has swelling, you can often identify that before they even sit down in your chair. You're walking them from the waiting room to your surgery. You can already start to pick up, if there's something going on. Any bleeding, so like bleeding when brushing, spontaneous bleeding from something. You want to record that in the patient's own words. So, they might say something like, every time I have a cold drink, this tooth feels really sensitive. So that's your cue to write that in their own words. Start questioning them. So, they'll point to which side it's on. So say, oh, on the right hand side, is it the top or the bottom? Front or back, can you point to me which tooth you think it is? And that can give you an indication as well of what the problem might be, which I say we'll talk about in a second. Or, sometimes my gums bleed when I floss, something like that. Write it in the patient's own words. And that's the best way to do it kind of medical legally so that, when it comes back to it, you have quote marks of what the patient said exactly. Okay. So a really good way to take a complaint history or pain history is to use this acronym. Some of you might remember this from uni. When I teach this, I get mixed responses of, some unis seem to teach this and some don't, but it's a great way if you can memorize this in your head. And it's one of these where when you get in the habit, you just automatically do it and you'll go through it without even really having to remember the acronym. You'll just kind of remember the sequence. So basically, if your patient comes in and gives you, so say they say this tooth feels really sensitive, okay? So, like I said, you're going to question them more about the site. So, can you identify which tooth this is coming from, top or bottom, left or right? Where is it? The onset. So, when does it happen? Is it when you have a cold drink? They're telling you they have a cold drink and it feels sensitive. Is it you have a cold drink? Does it last for a while? What happens? They'll usually tell you some of these things before you even get to the later bits in the list. So, when does it happen? What makes it happen? What is the character? So, is it like a short, sharp pain? Is it a dull, continuous ache? Radiation. So, can they feel it? Sometimes they'll say, I can feel it in my ear, I can feel it in my jaw or my neck. Alleviating factors, so anything that helps it. So, often, if, say, a patient has maybe a crack in their tooth, something like that, actually biting and putting pressure on the tooth can alleviate that pain. So, this, like I say, helps you, is starting to, in your head, make you tick and think, what could be the patient's issue. Time that it lasts for. So, if it is a pain or a sensitivity, is it like a short, sharp thing and it goes? Is it a lingering pain? Anything that exacerbates it. So they might say, I eat something sweet and it gets worse. And how severe is it? So ask the patient, please say, on a scale of 1 to 10, how bad is the pain? And sometimes they'll come in and they'll be like, oh my God, like this is awful. I've got this. It's been going on for ages. And you'll say, how on a scale of 1 to 10 would you rate it? And they're like, oh, like a 3, so it gives you a good clear picture of how it is for the patient. But again, you have to remember that people's pain thresholds are different as well. But generally, if they're telling you it is like a 7 or above, then, we have an issue that needs to be dealt with pretty quickly to get that patient out of pain. Okay, so if you can write that down if you want, or obviously if you watch this back, take a picture of your phone. Socrates, so it spells out Socrates down the side is a good one to remember. So social history, again, even just chatting to your patients coming in from the waiting room, you can ask them about their job, how's their day been, what have they been doing? They might tell you, they've been to pick their kids up from school, they've been at their job, which is XYZ. Even just like smell of tobacco from them. Again, you get all this before you even look in their mouths. So you want to know about any tobacco use, you want to know about their alcohol intake, any sort of recreational drug use as well. We actually include that on our medical history forms now. I know not all practices do, but actually people are very honest about it and, tell us quite a lot about what they get up to outside of work. Their occupation as well. So some occupations will obviously have an effect on your dental health. Their marital status, whether they have children, new parents, might not be looking after their oral hygiene sometimes as well as they usually do because they're absolutely knackered from looking after a baby. Their living arrangements, you get things, we all know you get things like, I'm having my bathroom renovated, so I've not really been using my floss, things like that. Holidays, the classic, didn't bring the electric toothbrush with them, and hobbies. I put a picture of a jockey here because I have a patient who's a jockey and he breaks his teeth all the time. So that's the one I always think of when I think of kind of strange jobs or hobbies that people have. So, it's the kind of thing that people do, but you don't wear a mouth guard for. So these kind of sports that people do and don't wear a mouth guard are quite hazardous for their teeth. So yeah, you'll get a good social history of people that like to chat. Okay, so why is all this important? Why do we care about people's jobs, social history, about what they do in their spare time, recreational drugs, smoking, all these kinds of things, because it forms part of our diagnosis. So when you're doing periodontal diagnosis now, all these things are included. So, you can put these down as risk factors alongside your diagnosis. So, like I say, things even like poor diet now, certain medications that they take, stress, there's even emerging evidence for things like nutrition, alcohol use, and whether your patient is overweight. And then obviously things that are that can't be changed. So the socioeconomic status, their genetics, pregnancy, age, all these different things, can be factors in periodontal disease. So it's great that we have these included in our guidelines now as well. So you've pre-assessed your patient, you have an idea in your head of whether they have any problems, what the problem might be. Maybe they said there's nothing wrong, everything looks fine. But maybe they've also told you that they've not attended the dentist in 7 years, and you think, right, I wonder what I'm going to see when I look in their mouth. So we'll move on to the clinical examination part. So three components to your clinical examination. Okay, so we're going to talk about your soft tissues and extraoral exam first of all. So again, this is a slight bit of pre-assessment. So when you're walking your patient from the waiting room through to your surgery, you can already be starting to look at your patient and, kind of bald men that have things on their heads, suspicious moles, any lesions, extraorally, you can start to look any sort of asymmetry as well, so any like lymph node swelling, anything like that. You can start to look for that before they even sit in your chair, just while you're chatting to them. Um, you're going to have a good extraoral palpation of their lymph nodes and TMJ. You'll say to your patient, I'm just feeling for any kind of irregular lumps and bumps. And we do this for every patient. We reassure them that we do this for every patient. It's part of a thorough clinical exam. Depending on what they've had done before, patients can find this a bit invasive because often, you're going, I'm going to show you a video in a second of how to do a really thorough examination, but often you're going, you're pretty much going down to the collarbone. And for some people, it can feel a little bit, um, almost a little bit claustrophobic and a bit invasive. So just warn them about what you're going to do. Just say, this is part of our examination for every patient. We check for anything suspicious, any lumps and bumps. Have you noticed anything? So ask them first of all, have they noticed anything? And then basically work your way around doing the exam. Obviously just ask their permission first though. So, depending on who they've seen before, they might never have had a really thorough soft tissue exam. So, explain why, ask their permission, and if all's good, I'll show you how to do it in a second. We're then going to look intraorally. So we're going to use our mirror to look as far down into the oropharynx as we can. We'll get them to stick their tongue out and things as well, which we'll see in a second. And like I say, tell them why you're doing it. So, the Mouth Cancer Foundation have got great guides for patients and for personal exams, guides for, I always say to my patients, if you have anything in your mouth that you notice, if it's there for 2 weeks and doesn't go away, come and see us again, please, because we'd rather you came and told us, don't worry about wasting our time. If it turns out to be nothing, so be it, but we would rather see you just to check it out. Okay. So this is a video from the lovely Joss Harding from the Mouth Cancer Foundation of a really thorough check. Okay, so she's going right underneath where the lymph nodes are, right down the side of the neck where the cervical chain lymph nodes are, down to the collarbone. Okay. So if you have patients with really high neck close, you might need to warn them just that you're going to go slightly underneath. Okay, so she's going right the way around the cheeks and the lips. Just checking for anything abnormal. Again, palpating as well. So she's doing this with her finger and thumb to check for any lumps that aren't visible. Okay, so get your patient to lift their tongue to the roof of their mouth and then go for either side. All right, and then she's got a bit of gauze and she's just getting the end of the tongue and just moving it as well, just so she can check right the way underneath. All right. And then, yeah, check their palate, get them to stick their tongue out and say ah, so you can see as far down their throat as possible. Um, I've given up on saying left and right to patients now. When I say put your tongue to the left hand side of your mouth, I'll say put your tongue to the left hand side of your mouth, and I'll just tap their cheek because they get a bit they get a bit flustered and confused sometimes, and it doesn't go to either side, you know. So just give them a little tap, and they'll know which side to go to. All right. So then once we've done all the soft tissues, we're going to look at their TMJs. So things like clicking, so TMJ clicking. Any sort of crepitus. So crepitus is basically when there is a deformity in the meniscus in the TMJ. Okay, so you get this. It's a very specific sound that once you hear it, you'll remember it. It's almost like a kind of crunching sound. Can be quite common in people with arthritis and things like that. Any sort of limited opening, any sort of deviation when they open, tenderness of muscles of mastication. Obviously, that's going to maybe tell you that your patients are grinding, clenching, doing something like that. Again, your patient may well tell you this. I'm waking up with headaches. I'm waking up with a sore jaw. I can't open my jaws fully as I used to be able to. And like we say, you're looking at the lymph nodes as well for any kind of lumps, any sort of swelling that shouldn't be there. Okay. So for your soft tissue and your extraoral examination, if it is something that you can photograph, ideally photograph it, okay? So photographs are your best illustration of any sort of soft tissue lesion. They're great for doing a referral. You know, if you're referring on to someone, they will be very thankful if you can take a photograph of whatever you've seen. Obviously, you know, measure it as well. So, you know, get a perio probe, like a UNC 15 or something like that. Put it beside the lesion, showing how big it is, and take the picture. If you're then going to get your patient back, you maybe in 1 or 2 weeks to check that it's gone before you refer them, you then can use that as your reference. You know, has it got bigger? Has it got smaller? Is there more of them? If it's spread throughout the mouth, if it's something like that. And like I say, you can track changes over time. So say you get your patient back in a week's time and it's changed, you then take another photo, you then can use that in your referral. And, you know, we have referred people before where actually having the photograph has helped them be seen more speedily because I know that, you know, we're supposed to have 2 week wait and all that, but often that is longer than it should be. So it does help patients be categorized correctly when you've included photos. So if you can, you don't have to have a fancy camera, anything like that. You can do it on a phone. You know, just try and take a picture of it if you can. Okay, so we're going to move on to restorative examination. Okay, so again, even if you're not the one carrying out the restorations, you can still screen your patient. You can still identify anything that doesn't look right. We're going to assess each tooth in the mouth. So we're going to dry each tooth with a 3-in-1 for better visuals. Just get rid of any saliva that's sitting around. We're going to look at teeth. We're going to look at restorations, any sort of fractures, cracks, anything like that as well. You can note down. And things like non-carious tooth surface loss. So attrition, abfraction, erosion, and if you use indices for things like that, like BWE and things like that, you can note that down as well, okay? So for our restorative examination, photographs can be really helpful as well. So they're a really good way to illustrate the starting point, even if you're not the one that's carrying out the treatment. Great for patient education. So, you know, something like this, you can get up in front of your patient, you know, rather than hand them a mirror and they're kind of trying to do this and look upwards, you can show them a picture and say, look, you know, you can see you've got this old silver filling in the middle of your tooth. I presume that's quite old, at which point they're usually like, yeah, I don't even remember when I've had that done. And you can say, look, you can see this brown area on the side. If I can use my mouse, so just here, you can say, you know, this bit is broken and this tooth is going to need a restoration. If you're not the one diagnosing and treatment planning that, you can say, you know, this tooth is broken. I'm going to refer you to my colleague, whoever, and they can tell you what treatment exactly is needed, but it is going to need some treatment. So there's nothing wrong with saying that as a hygienist either, that, you know, you can identify that they need treatment of some sort and you can send them on. Okay. Radiographs as well for any sort of restorative treatment planning and assessment. So, you know, if you take radiographs for a perio purpose, even if you're just doing the perio treatment, you can still show your patient. So this is the same tooth. So that was it in the mouth in a photograph, and that is it on a radiograph. So you can say, you could see this broken bit. Do you see this? This is the silver, sorry, this white bit is your silver filling, and this kind of dark bit underneath is where it's not actually, you know, connected properly to the tooth anymore. It looks like there might be some decay there. and I'm going to need to either replace that for you or refer you on to someone else who can assess and let you know what you need to have done. So radiographs, like we say, need to be justified. So you need to justify why you're taking them. They need to be taken by a qualified operator and reported on. So dental therapists and hygienists can report within their scope on radiographs as well. Providing obviously you qualified either after it was included in your course or you've done the course. So if appropriately trained, like we say, dental hygienists and therapists can refer a patient for an X-ray, take responsibility for taking an X-ray, and perform the operator roles. And we can clinically evaluate images where but that's within our scope and experience, basically. So unlikely to include things like CBCTs, cephalometrics, all that kind of thing. So, anything that's within our scope that we can diagnose and recognize on an X-ray, we can evaluate and report on that X-ray. If it is something outside of your scope, you shouldn't be prescribing, you can't prescribe as a hygienist or therapist CBCT. You will need a dentist to do that, and you would also need a dentist to report on anything outside of scope. So if there is say a periapical lesion that you've picked up on a periapical radiograph, you can identify that and you can note it down, but you'll then need your dentist to report on that radiograph and say that it is periapical infection or whatever it turns out to be. So how often are we taking radiographs for our patients? So for adults, if they're high risk, and for kids, if they're high risk, it's every 6 months until they have no new or active caries. Moderate risk, same thing, every 12 months for adults and children. Low risk for adults, every 2 years. This is where it differs slightly. And for kids, if they're low risk, every 12 to 18 months when they've got their primary teeth, and every 2 years when they've got their permanent dentition. Okay. And how do we work out? So how do we work out what risk category that we put these patients in? So I'm going to make this bigger in a second so you can see it. It's very detailed, but this is the FGDP guidelines on how we work out our caries risk assessment for a patient. You can see it's quite busy. There's quite a lot going on. Guidelines on when to take are on there as well. So, I mean, if you would like, you can print this out. You can have it linked on the desktop of your browser on your computer. Loads of different things. So, the patients, if they're in a socially deprived area, if they have low knowledge of dental disease, how often they're attending, fluoride in their water, dietary habits, oral hygiene, saliva, loads of different things. Basically, your kind of biggest indicator of when you're going to take radiographs for people on how high or low risk they are is their previous caries experience. So, if it's someone who has continuous loads of caries, they've maybe come in, they've had 5 fillings done recently, you're going to take X-rays for that patient in 6 months' time, definitely, because they're very high risk. Basically, they're either high risk, low risk, and if they fall somewhere in between, then they're moderate risk. Okay, so as I say, get this linked on your desktop, bookmark it, and if in doubt, just have a wee look at it. But no one is going to come to you and say you've put someone in the completely wrong risk category. And once you get going with it, it's quite easy to work out where to put people. And like I say, just something like that where they tell you they're having 10 cups of tea a day with 4 sugars in each, they're probably going to be in the high risk category. If it's somebody that walks in with a completely unrestored dentition, no restorations, good dietary habits, good oral hygiene, they're probably going to go in the low risk category. So, you can work that out as you get used to doing this. Okay, so for your restorative examination, there are certain things that we can do to investigate things a little bit further if we need to. So vitality testing teeth, we can do that basically just to check whether they are still alive or not. Whether, you might get a patient come in with a tooth that looks a bit dark, and you want to just check whether it's still vital or not. Maybe it's not had an endo, it might look all right on a radiograph. You don't really see anything going on with it. You can test it just to see whether it's still vital or not. Tooth sleuths, that's that thing in this top photo here. So they look a bit like a toothbrush with no bristles, basically like a toothbrush handle, and those are for checking for cracks in teeth. So if a patient has kind of strange symptoms where you can't really see on a radiograph that there's any caries, and there's maybe no recession that would cause their sensitivity, they're saying it's when they bite, things like that. Basically, what you will get with a tooth with a hidden crack is that when they bite on something and then release, they'll get pain. So with the tooth sleuth, you basically just take it around all the different cusps of the teeth and see whether that happens. And if it does, that kind of helps you start to identify where the crack could be if there is a crack. Okay, so something again you'll probably find in the drawer in your practice, that you can use if need be. Impressions as well, if you want to do study models, anything like that, to monitor tooth wear, you can take impressions. Slightly more modern version of that is doing digital scanning. So, you can digital scan your patients and you can, have different scans over time that will compare different things. Okay. And again, we'll talk a bit more about that in a second about how we can use scanners and whatnot. But you can use them for quite a lot of different things actually that you can incorporate into your appointments as a therapist and a hygienist. So periodontal examination, okay, I'm sure we're all very well schooled in this, but risk factors, like we said, you've probably found out all about these in your pre-assessment. So you will know whether your patient smokes, hopefully before they even come in, if they've been honest on their medical history form. You can question them about genetics. So, do they know if they're coming in saying they've got, loose teeth, something like that, lots of bleeding from their gums. You can ask them, do you know if either of your parents have lost teeth at a young age, or if they had any problems with their gums that you know about? Stress, when you ask about their job, they'll often tell you about how stressed they are. Any medication should be on their medical history form as well. So, as we know, our BP is our starting point. So it's basically a map. So the BP is like a map. It's going to tell you where to go next with your investigations for your perio. Okay. So we're then going to do some further assessments if need be. So things like plaque percentages, bleeding, on probing percentages, 6-point charts if need be, mobility, furcations charted down as well. And then radiographs, we need these now to complete our periodontal diagnosis. Okay, so let's talk a little bit more in depth about this. Okay, let me see. Perfect. So our BP. So as we know, we're scoring each sixth of the mouth. Okay, we're giving it a score, and then if need be, and there's a furcation there, we're also putting our little asterisk as well. So all new patients should have a BP carried out, regardless of how many, how many teeth they have, unless they have no teeth, obviously, or not enough in any sextant to score. For patients with code 0, 1, or 2, you want to record a BP at each routine examination. If they have codes 3 or 4, then you're going to go down a different pathway, okay? You're going to move past a BPE and you're going to do some more detailed periodontal charting. So if the patient has a code 3, you're going to carry out your initial therapy, including self-care advice. And then once you have done your initial non-surgical periodontal therapy, you can then record a 6-point pocket chart afterwards. If they are a code 4, then you're going to look to record a 6-point perio chart beforehand and also after you have carried out any periodontal therapy as well, okay? So for patients that have undergone initial non-surgical perio treatment, surgical perio treatment, whatever it is that they have had, you want to record their 6-point chart at least annually, okay? Just to monitor and to make sure that things are not going downhill again. And you do not want to use a BP around implants. This is a common question as well. So not for implants, because of the different kind of heights of abutments and things that you can have, different lengths of abutments you can have on implants. Ideally, when an implant is placed and fully integrated, you want to record the probing depths around it. And then you'll double check those basically to compare at each visit. So, it wouldn't be unusual for an implant to have a healthy probing depth of maybe a 4 or 5 millimeters. And if that's normal for that implant and for that patient, then that is okay. All right, so we want to take radiographs for each sextant that has a code 3 or 4. The type of radiograph is a clinical judgment, okay? What the guidelines say is that for a code 3, bite wings are acceptable. However, periapical are still your gold standard. So, if you're starting off, you don't have any radiographs, I would probably take some periapicals for the sextants that have got a 3 or a 4 in. If you, though, have some radiographs, so say this patient has seen a dentist or another dental care professional, maybe 6 months ago, they've had some radiographs taken, all you have is some bite wings, you need to go back to your justification for your radiographs. So, are you going to be able to justify taking radiographs for periodontal diagnosis when your bone levels are not going to have changed probably that much in 6 months? So you have to just judge, on an individual basis, whether you can justify that. Same with patients that have come from another practice. Maybe you don't have anything. If they say, oh, I went last week and they took some x-rays, I would always err on the side of caution and just request those, first of all. It doesn't mean that they're going to be the ones you need. You might still need to take some extra ones to make your diagnosis, but at least you're not exposing the patient unnecessarily. So we're always as low as reasonably possible with our radiation. Okay. And when you do a 6-point chart, you always want to record bleeding on probing as well. So you want to make sure that you are monitoring and diagnosing and noting down active disease. So, if you have a pocket of 4 millimeters that isn't bleeding, that is different than a pocket of 4 millimeters that is bleeding. Okay, so we're always making a note of bleeding on probing for every site as well. So we've done our clinical examination. Okay, we have noted down everything we've seen in our patient's mouth. Let's move on to diagnosis and treatment planning and see where we go next. Okay. So if we are doing restorative diagnosing and treatment planning, radiographs, so these radiographs that we've taken are going to be useful for all aspects of treatment planning. So they're going to illustrate the extent of carious lesions. Okay. So before you're going to carry out a restoration, you want to discuss with your patient, any sort of likelihood of postoperative discomfort if the restoration is going to be very deep, very big. You want to talk to them about the likelihood of them needing root canal treatment in the future, again, if it's very deep and close to the pulp. Whether the direct restoration is the optimal treatment, and we'll talk a bit more about that in a while, just about how to decide if you're going to refer them on. And as I say, offer referral if appropriate. So if you feel that the tooth is quite broken down, you always need to offer your patient, if there's a better, maybe more gold standard option, you can say, I'm a dental therapist, I can carry out an amalgam, a composite restoration for you, whatever it is that you're doing. But, this tooth to me looks like it might benefit from something like maybe a crown or an inlay or an onlay. That's not for me to decide, but I can refer you on to Dr. Whoever who can have a look at that for you if that's a route you'd like to go down. And just detail to them, why that might be a better option than a direct restoration. Okay. Photographs and radiographs are really useful for co-diagnosis. So when we talk about co-diagnosis, what we mean is basically guiding the patient to recognize what it is they need without you really even having to tell them. So, you get this photo up, you get this radiograph up, the photo immediately they go, oh, what's that? Why does it look brown? What's that silver thing? You can then say, right, so this is your all silver filling. This part of your tooth is broken. When you look at the radiograph, you can then say, yes, it does look like this restoration is leaking. It looks like there could be some dental decay going on underneath that. And from that, basically, medical legally, that protects you as well because you have fully explained to your patient. You're basically gaining consent that way, as fully informed consent. You're still going to get them to sign a consent form, but you've taken them down the path of identifying it themselves almost, and you telling them what you're saying, and by that point, they know what they need and they're aware of why. For our periodontal diagnosis and treatment planning, this is what we used to have previously before the 2017 classification. We had things like, we could just write chronic periodontitis, aggressive periodontitis, abscess of the periodontium, things like this. It is now much more complicated, as we all know. And we've got our lovely little flow charts. Again, I have these bookmarked on my browser at my practice. Just because when you have those days when you feel like, you just think, right, I just wanna double check what I'm doing here. We've got a little flow chart that we're going to work through. So we want to take you through the BPE. It's quite a good guide actually of where you're going to go after you've done your BPE. And we're then going to stage and grade patients that have any sort of bone loss that you see on the radiographs. So like we say, radiographs are super important now. You need those to be able to make a diagnosis for your perio patients. So radiographically assessed, then we're going to decide, is it localized or generalized? Is it stage 1, 2, 3, or 4? And is it grade A, B, or C? We're not going to go through that fully. Don't worry, I'm not going to bore you with the details tonight. But if you want to look at that more in depth, loads of great webinars about that. Great BSP webinar taking you through that from when this all first came out. Again, we need to know about our risk factors. So hopefully if you've done a good pre-assessment, you'll have all these to note down as well. So you might have something like localized periodontitis, stage 2, grade B, currently unstable, and the patient is a smoker. Okay. And for our treatment planning, we have another lovely flow chart that's going to take you through steps 1, 2, and 3 of what you're going to do with your patient, okay, how you're going to treat them. All right. So when we talk about diagnoses, we are talking about there are two different types. So global diagnoses are basically risks, and your specific diagnoses are things like gum disease, periodontal diagnosis, and specific teeth diagnoses. Okay, so your global diagnoses might be your patient's risk of oral cancer. So if your patient is drinking 30 units of alcohol a week, they're smoking 40 cigarettes a day, they're definitely going to be at a high risk of oral cancer. So you're going to note that down. Risk of caries as well. So, like we said earlier, in the guidelines, it will tell you whether your patient is a high, moderate, or low risk of caries. You can note that down as well. The risk of periodontal disease. So again, if they have maybe a genetic risk, they'll often tell you, my mom lost all her teeth when she was 25, or something like that. If they are smoking, if they have poor oral hygiene, all these types of things, you're going to be at higher risk of periodontal disease. You can note that down as well. And then risk of occlusal dysfunction or non-carious tooth surface loss. So, if they are doing things like drinking energy drinks all the time, drinking smoothies all the time, trying to be healthy, they're grinding their teeth, they're drinking Coca-Cola all day, they're going to be at a higher risk of erosion, attrition, all these types of things. Okay, so you can note that down as well. Specific diagnoses are things like, say, like your periodontal diagnosis, so the staging and grading that we spoke about earlier, any sort of kind of pain history that you've taken as well. So, like we say, if you're using a comprehensive pain history, even if it's something that you're not going to be dealing with yourself, you can write, upper right 7 irreversible pulpitis. So, if you've taken a pain history, the patient's saying it's keeping me up all night, they've not rang to tell your receptionist before they turn up in your chair. It's keeping me up all night. Painkillers aren't working. It's throbbing all the time. Nothing helps it. Nothing triggers it because it's there all the time. You're going to suspect that that's an irreversible pulpitis, and you're well within your rights to note that down. If you've taken radiographs and you're diagnosing as a therapist, you can write down upper right 6 MO caries. Even as a hygienist, you can write something like radiolucency seen on radiograph, upper right 6 MO, referred to whoever for a diagnosis. Okay. So you're going to record all these discussions that you've had with your patients. You're going to discuss your clinical findings with them. You're going to explain all their diagnoses. You're going to tell them if they're high risk for something. You're going to tell them what's going on in their mouth. You're going to prioritize the problem list. So obviously, first of all, is obviously if they're in pain, we're going to try and get them out of pain first of all. And that's likely most of the time going to involve a referral to someone else. So we're going to refer them on to get them out of pain first of all, and then we're going to prioritize what happens after that. You need to ensure the patient understands the information. So, like I say, the maximum amount of records you can take, the better. So, if you have photographs, radiographs, maybe digital scans, things like that as well, to show them any wear to their teeth, and you can show them all of that. And that is how you create your code diagnosis. Okay. Discuss all the treatment options. If you're doing NHS care, private care, mixture of both, you have to discuss all their options with them and give that to them. You have to go through the prognosis, the risks, the benefits, the cost of each option. If you're going to do a restoration and it looks like it's quite near to the pulp, you need to discuss that with your patient and say, it may well be that this tooth is going to need a root canal treatment in the future. It looks like it's very close to the pulp. On this x-ray, do you see this big dark area here? And it is likely that you could have some discomfort from this tooth in future. And if you're happy to try, we can try the restoration and see how we go. Discuss the timing and the number of appointments as well, and like we say, costs. What it's going to cost them, how long, kind of time-wise commitment it's going to cost them as well, and explain any sort of long-term further cost of maintenance and replacement. So things like aesthetic composite bonding. That is where people are finding themselves in sticky legal situations, is where they have not pre-prepped their patients that this is going to require long-term maintenance, that it's not going to last forever, that it might need replaced in 3 to 5 years. This is all kind of co-treatment planning with your patients. So you're talking to them about what they want, what their wants and needs are. Some people might not even, they might not want to be healthy, they might not be interested. So, you need to make sure that you're aligning with their goals as well. You're obviously still going to tell them everything, and they can then accept, refuse, leave it for later, whatever they want to do. But as long as you've done your bit and told them, that's absolutely fine. So we've done our bit. Something is outside of scope, something maybe is in scope, but we're going to refer it to someone else. Who might we refer to? So within your practice, if you're lucky enough to work with an oral health educator nurse, you might be referring patients to them for oral hygiene instruction, for fluoride varnish application. You might refer to a hygienist in the practice, a therapist in the practice, general dentist, specialist. If you have these all within your practice, you can refer on to any of these people if you think they are the best placed person to see your patient. Outside of your practice, you might refer to secondary or specialist care. Community services, you might refer them to their GP if there's an issue, a medical issue that you need them to look into for you, or any sort of safeguarding concerns, welfare concerns, you might be referring to social services as well. So referral should be done in a timely manner. You need to include all the relevant information. Like we said earlier, if you can include as much information as possible, so x-rays, photographs, you also need to provide the patient with a copy of the referral as well. So when you send it off, you also will send it to your patient. It should be followed up, so you need to keep a note of who you've referred and when, if someone has not got back to you, and acknowledge that the referral has been sent. I mean, most places you will get at least something to say, thank you for your referral of Mr. Whoever. We aim to see them in how long, or, I've contacted the patient to book an appointment, something like that. And then they'll usually keep you updated as well, if the patient doesn't attend an appointment, or if they do attend, have an assessment, and whatever the outcome of that is, they will usually keep in touch and tell you about that as well. I would say most services nowadays have something on their website, so they'll have a specific referral form that they want you to use. Really easy. You can upload photos, you can upload radiographs, click a button and off it goes. So gone are the days where we're sending, letters and things like that. And we've got like NHS portals and things like that now as well. So when are we going to refer? So if something is outside your scope, obviously it goes without saying that you're going to refer. So, any restorative work that is outside your scope, endo, prosthodontic things, implants, obviously oral surgery, orthodontics, periodontal as well, if you're referring on to perio specialist or a dentist with special interest, whoever it is you might refer to. Like we said, though, you can also refer to other people, other dental care professionals. So, maybe you're a dental therapist and you have an arrangement in your practice that you work with maybe another dental therapist or a hygienist, who really loves doing non-surgical perio, whereas you like doing maybe restorative work, something like that. You can always refer on to someone who has the same role as yourself. So this may be necessary treatment, it might be elective treatment, it doesn't really matter. If it is in the patient's best interest to be referred, then you can refer them. So oral lesions that are present for 2 weeks or more, we need to refer. Okay, so 2 week wait referral to oral medicine for assessment and potential biopsy. Obviously, they will be the one to decide on that. Like we said, educate patients, like educate, just how to check their own mouth, what's normal for them, what's not normal for them. Patients will come in with things where they will tell you, oh, I've had this looked at before. I know what this is. Fine, that's okay. Anything new, anything that they don't know about needs, anything changes even. So, take photos of what is there. They might say, oh, I went a year ago and I had this looked at and it looks exactly the same. Fine, take a picture of it at the initial exam, check it each time compared to the photo. If it changes, refer them off. So, periodontal conditions require an input from another professional, you can refer. So again, within the practice, things you might refer for, so oral hygiene visits, like I say, you can refer to someone else that's a hygienist or a therapist. You can refer to a general dentist. So for perio, basically, if something's grade 3 mobile, obviously the guidelines tell us now that it should be extracted. Obviously, that's not our decision to make. We can tell the patient that, this is what's suggested, but you will refer them to Dr. Whoever to decide fully, what will be done with that tooth. Specialist care, like we say, within the practice as well. And like we said, GP if there's any health concerns or any risk factors that need to be managed. Some people might want to be referred to like smoking cessation services, things like that as well, which you can do. All right. So basically what the guidelines say, the BSP guidelines for periodontal patient referral will say that the stage and grade of disease and the complexity of treatment needs to be taken into account. Basically, the presence of their genetic and lifestyle behavior risk factors taken into account when deciding whether to refer as well. Okay, so if a patient is grade C periodontitis, it is suggested that you refer that patient, okay? After you've given them the initial advice on oral hygiene and their risk factor management. So restorative referral, when do we want to refer? So we spoke a bit about this earlier. So if you, even if you're a therapist and you're going to be doing some restorative work yourself, if a tooth would be better with an indirect restoration, you can refer the patient if they're willing. Some people will just say, no, I don't want to pay for a crown or an inlay or anything like that. I would rather just have a composite or an amalgam or whatever it is you're going to do. That's absolutely fine. But again, that's part of your co-diagnosis and your consent. You're going to make sure that you document, was discussed with patient that this tooth has, a lack of structure left, might not be suitable, restoration might not last, all these different things, offered to refer them to whoever for assessment and for their discussion, patient declined. Fine, if they decline, that's okay. So if we have teeth with multiple loss cusps, thin walls, extensive, marginal ridge loss. So like this six here, this is a lower six. So this was a situation where I had done these direct restorations on either side. Was discussed with the patient when they came in. They were a direct access patient. This tooth in the middle here, you can see actually just here, this cusp is slightly fractured as well. There's a lot of open margins around this huge amalgam. On our X-ray, this was really deep as well. Discussed with the patient, direct restoration might not be the best for this. It's doable. However, if you would like, I can refer you to Dr. whoever to have a look at this. And this patient actually was seen by the dentist and decided to have an onlay on that tooth instead. So caries near the pulp as well. This is one that you can decide, within your confidence and competence if you're a therapist as well. So the evidence shows us that caries can be underestimated on a radiograph by at least half a millimeter. So if it looks like it's in the pulp, it's probably in the pulp. If it looks like it's very near the pulp, it's probably in the pulp. So you're going to take into account your patient's symptoms. You're going to take into account, is it in my patient's best interest? If this looks like it's near the pulp and it's maybe going to be in the pulp, is it in their best interest that I open this up? I find out it's in the pulp. I then have to dress it. The patient is then potentially in pain. Or is it better for my patient that I refer them, maybe get an opinion on this radiograph from a dentist colleague, endodontist, whoever it is you work with, and then it's done in one visit. They're having one lot of anesthetic. Dentist opens it up. Maybe they find that actually it's not quite in the pulp and that they can, do a pulp cap, something like that. But then if it does turn out to be an endo, the patient is already well prepped. The patient knows that that might be the outcome, and the dentist can then just carry on and do that with the patient's consent. So, you have to just judge these things on, on your, say, your competence and whether it is the patient's best interest for you to be the one to do it if you're a therapist. So if the tooth has had endodontic treatment, the evidence tells us basically that the long-term survival of endodontically treated teeth is better with an indirect restoration to help strengthen that tooth. So you always have to give your patient that option. And this is one of my patients as well. Actually, he decided that he did not want a crown on this tooth, so we actually just did end up doing a composite. But he was told, I can refer you, I can get an opinion from a dentist on this. Do you want me to do that? And he just said, no, I don't want to spend the money. I've already paid for a root canal treatment on this tooth not that long ago. It's been fine, and I'm quite happy just to have that silver filling replaced. So it had this like horrendous overhang on the back. Again, symptoms, we spoke about this a minute ago, but if you feel like your patient is heading towards the irreversible pulpitis zone, refer them on. Get an opinion at least. It's nice if you work in a team where you can go to your dentist colleagues and show them a radiograph, tell them what's going on. They'll likely say, no, book them in with me, I'll have a look. And, if need be, they might need an endo on that too. All right, so this is one of my favorite slides. So You need to know as well when to say no. So if you are a therapist and you're carried out restorative work, you have to know when to say no. So if you are assessing the patient yourself, which is obviously what we're speaking about this evening. However, also if you're working under referral, if you are being referred things that are maybe questionable. So what I have done, I've collected a group of radiographs from, so I went around all the groups of therapists that I'm in WhatsApp and just said, send me, the worst referral you've ever received, the most worst, most ridiculous. So the point of the slide is basically don't be afraid to say no. So obviously if you do an exam and you see something like this, refer on. If you refer things like this, also don't be afraid to say no. So some of these are extraction material, 100%. They're not even restorable, but these are all genuine things that therapists have been referred to restore. Don't be afraid if you are sent things like this, like just don't get yourself into trouble by trying to do anything like this. Just send it straight back to where it came from. Tell your patient very nicely that, it looks like there might be some infection on this tooth or broken or, outside your scope, and off it goes back to the dentist. So main thing, like we say, always the GDC always go back to confidence and competence. So if you do not feel confident, you do not feel competent, even if it was is within scope, but you just don't feel like you're not confident to do it, that's absolutely fine. Just refer on. That is the main thing is, if you want to refer on, you're absolutely fine to do that. So if you're wanting to get started with carrying out exams, best way to start is speak to the team, discuss with the practice owners, utilizing your full scope, carrying out exams. You have to outline the benefit to them, okay? Ensure the team are aware of your scope of practice and they're calling you by the correct title. So whether you're a hygienist or a therapist, they need to call you by the correct title. So therefore, if you're a therapist and you're diagnosing caries and you're going to maybe carry out some restorative work for patients, the patients need to be aware of, what you are. I know someone who's got in trouble with the GDC because the reception were calling them a hygienist. They then were carrying out restorations. They got a complaint. It was all resolved before it made it as far as the GDC, but it's just one of those kind of tricky, sticky situations that you'll not be in if your reception, your treatment coordinators, your nurses, dentists, everybody is calling you by your correct title. And you do have to have protocols and referral pathways for this to work as well. So what I mean by that is have some sort of protocols in practice, but also, you will know if you know your dentist well, you know your specialist well, whoever it is you work with, you will know you'll meet patients and you'll think, right, that's outside my scope, and you'll quite soon get to know who you're going to refer that to. You might have dentists that you work with who are mainly doing implants, some who might like to do ceramic smile designs, some that love doing endo, maybe endo specialists, and maybe you work with an orthodontist or a dentist who loves doing ortho. Hopefully you have these people at your disposal. If you don't, you are well within your rights. I know there are lots of discussions on the forums and things about, oh, will they accept a referral from a therapist or a hygienist? The main, well, a couple of main reasons of why they get bounced back is, you can't treatment plan for that person. If you're referring outside of the practice or inside of the practice, you can't say, this patient needs a root canal treatment, right? You can say this patient has XYZ symptom. There's a periapical radiolucency on this periapical radiograph. Please assess. Okay, so you're always just saying please assess, but this is what I've seen. Okay, so a lot of the time when they get bounced back, it's because someone has done a referral. I think there was an example a while back on one of the forums of you referring and you're saying, this person needs to have their wisdom teeth extracted. You as a therapist or hygienist can't decide that, but you can say these are the symptoms and this is, I would like you to assess them for this. Okay. Like we say, feel confident and competent, research courses to attend, ask to shadow others in your practice. The way I have learned best in all the years I've been doing this is by watching other people, go and shadow other therapists, hygienists, dentists, anyone who's doing exams to start with. Quite nice to follow a patient journey as well. So, if you see someone and you refer them for for an assessment with one of the dentists for something outside of scope, see if you can nip in just and see what they do in that appointment, see what they do, maybe that you don't do. Just find out how they work and how they like to work, what information they want you to send on when you refer people. Practice treatment plan on current patients. So what I mean by that is, pick a patient who's had a big treatment plan in the past, have a look at their radiographs without looking at their treatment plan. and find out, kind of note down what you would have seen on those radiographs and what you would have seen from the photos that have been taken, and just kind of challenge yourself a little bit to try and do a bit of a kind of fake treatment plan on them and see how it matches up with what was done. And like I say, use your colleagues for tips and advice. Working in a support practice, this it's hard to make this work without supportive colleagues. So, just reach out. Hopefully they've got a nice kind of open door policy where you can go in, you can ask them for things, and you can go to them. I will go to the dentist that I work with. They will also come to me to ask opinion on things. It's great to have that kind of relationship where we can just bounce ideas off each other and treatment plan together sometimes for things that are maybe outside of scope. If you've got a patient that's got a treatment plan where some things are in scope, some things are out, I'll often sit down with the dentist with the radiographs and the notes and just go through it together and just split it up, who's going to do what and what stage or what way are we going to do it, who's going to do what first and what way does it need to be done. So that is probably the most important thing out of all this is having a supportive team. Um, if you are looking to get started, if you're a therapist, I do run a course called Restore. Siobhan mentioned that at the start. So the idea of this course, basically, we created this because, therapists are increasingly being asked to do exams in practice. They're also being asked to treatment plan, diagnose. If you're like me and you did this a long time ago, maybe you did it recently and you've just not been using your full scope for a while. It's quite daunting because you have to be confident and competent, like we said, and that's the idea is to try and help people become more confident and competent. So, we go through everything. We go through kind of how to work, protocols, referral pathways, communicating with your patients, digital dentistry, and maintaining composites, and then we do a hands-on day. So the next one is the 25th of April in Stevenage. And we do a really good intraoral camera workshop with Action. We then go through everything restorative. So we start from the start. We do isolation matrices, and we do kind of practicing with sectional matrices as well, rubber dam, all that kind of thing. And we do caries removal, cavity prep, and we do hands-on workshops. We do an anterior posterior tooth. And then finishing and polishing and maintenance, like we said as well. So we've done a little discount code just for this webinar. So if anyone is interested, you can obviously reach out to me. I teach this alongside Ebby Newman and Ilish Duffy. And like we say, the idea is that it is to help you as a therapist feel like you can do these things because we are all more than capable, but all we need is the support to be able to do it. So, like I say, there's a little discount code up there. I'm covering it. It is NSK10, and that'll give you 10% off if you want to do it. And so, as I say, just reach out if you want some more information. Thank you very much for listening. If you have any questions, hopefully Siobhan will be able to see those. You there, Siobhan? Let's have a look. Let's have a look in the chat. Da, 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 da.
Can you just
Oh,
move the
yeah.
slide onto the QR code, please?
Yeah, sure, no problem. So there's a discount for the NSK web shop as well, courtesy of NSK, which is WTE0326. We're going to put that in the chat as well. And your QR code there on the right-hand side just to scan to get your CPD certificate. Didn't do too badly for time. I thought I'd gone quite a lot over there. We got any
So just waiting
questions?
for some, everyone's just busy doing the
Yeah,
filling
no.
in the link. Okay. Brilliant webinar, Lauren, very useful to me as a hygienist. Can we do the course as a student, Lauren? They haven't graduated just yet.
Yeah, you can do the course as a student. Yeah, absolutely. It's quite good. And if you're graduating quite soon, it depends kind of where you are within your course. If you're about to graduate, I would say yes, but contact me. I don't know if you have, I'm on Facebook, Instagram, obviously, just search Lauren Long, you should be able to find me. But yeah, give me a shout and we can work out where you're at and what kind of stage you're at and if it would be helpful.
When is the next one, please, if we can't attend in April?
There'll be one later in the year, so probably September as well. Again, it'll probably be at NSK and Stevenage.
Did you say there was a video? I wonder what that was. What was that for, Heather? Lots of thank yous. Excellent, Lauren. Really enjoyed that. And just trying to keep, yeah. Will the course be in London? It's actually North London,
North
Stevenage. So
London,
it's
yeah.
about
So
45, yeah.
yeah, so the reason one of the reasons we do it in Stevenage is because the lovely NSK host us, but also because it's super easy to get to on the train. So I actually get the train from Edinburgh. I live in Edinburgh, so get the train down there. It's basically the last stop before you get to King's Cross if you're coming from anywhere north, and if you're around London, it's super easy to get to as well. So really good for transport. And there's a lovely Premier Inn next door that's about £40 a night as well, so it's really easy.
With the
Oh,
course,
someone's
could
asking.
you do only the hands-on day?
Yes, we could sort that out, yeah, if you wanted to do that, that's no problem. Yeah. Someone's
What
asking
was the
about,
name of the course?
yeah.
Yeah.
So that is Jimmy
Oh,
Macadissi. So it's JM Radiology, sorry, JM Radiology. If you Google JM Radiology, I know that as a BSDHT or BADT member, you get a discount on that course as well. So if you go into the members portal on either of the websites, you can get a discount on that as well. It's a really good course.
Vera said the video might have been for the classification. Do you think that's what?
I said there's a webinar from the BSP about the classification if you're wanting to get more familiar with staging
That
and
must be
grading
it.
and things. It might
Okay.
have been that.
Yeah.
And I see Joss is on, so thank you, Joss, for letting me use your video as well.
She was saying it was like the Eurovision earlier on when we were calling our own
Yeah.
places. Any planned courses in Scotland?
Yes, we might do Scotland soon. I say we're in Stevenage just now, but yeah, depending on how much demand there is, and we will do it in more places. So yeah, if you get in touch and let us know where you want us to go, then if we get enough people, we'll do it. Definitely.
Looking forward to incorporating this when I graduate in the summer. Fantastic. Thank you. Very helpful. I thank you for the session. Very informative. I've come across patients with retained roots. Uh, could I, how do I do the BP in such a case? Should I include
Yeah,
that tube
so
in the BP or not?
I don't personally, I don't actually know that there's any guidance on that. I know they're technically still in the gingiva, but they're not functioning, so I wouldn't include those.
Lucia, you only managed to watch part of the webinar. Well, it will be available on demand, and I'll just put the link in where you can go to my NSK in about 7 to 10 days and watch it back. And that
Mhm.
goes for anybody else because it was quite intense, wasn't it, Lauren? Just,
Yeah, there's
if
a
you
lot of
want to
info. I know
watch
there's a
back
lot of
and
writing
freeze
on
and
those slides.
if you want
A
to
lot of
take
writing,
notes.
a lot of info. Yeah, so if you wanted to go back through and pause and things, you can do that on the playback and just make notes on things and take pictures of slides and all that kind of thing, just to
Yes, again,
help
Haley,
you.
about 7 to 10 days.
Yeah.
I'm a new graduate. I'm wondering if you have an example template for a radiographs report.
I don't have a specific template just because we all do it slightly differently. But if you go to the FGDP guidelines that we referenced quite a lot during the webinar, they are now on the College of General Dentistry website. And if you go to the guidelines, it will tell you everything that you should include in your radiograph report, and you can then sort that out, however you want. It's good to go through with people in your practice as well, whether you want to have a standardized report, maybe the dentists or therapists or hygienists that you work with might already have reports. So it's helpful if everyone in the practice is using the same one so that you can all decipher each other's as well.
Just put the link back in. The QR code is on the right-hand side. Please answer all the questions, tick all the boxes. All the
Hmm.
questions must be answered correctly. While we're just waiting there, can we stage and grade a radiograph under prescription National Health Service?
Yes, you can diagnose within your scope whether you're working under prescription or not. If you're wanting to work under prescription in terms of treatment referral, you'll obviously then want your dentist to write a prescription for whatever you're going to do, but you can diagnose a patient outside of that, no problem.
Thank you, very interesting. And next week we have the air polishing panel. We have Kat Edney, Catherine Mayo, Amanda Harbour Harris, and Ibrahim Newman. So they're going to all go through different areas where they use air polishing, air powder therapies. That's very interesting. And they've been really popular to have the panel discussion on different treatments in surgery. And I know you ran
Hmm.
one last year, didn't you, Lauren?
Yeah, loads of
So
really good
that's next
questions
week,
as
yeah.
well.
Yeah.
Someone's asking if they found the right course by JM Radiology, prescribing and interpreting radiograph course for dental hygienists. Yep, that's it. That is it. That is the right one. So, yeah, you found it.
Any final questions before we go? Don't forget that that's a discount code for you, 40% off NSK products. That is something that NSK do as an educational code for you that attend these webinars to say thank you. Lauren, thank you very much.
Oh,
The
someone's
course on the
asking.
25th, will it be in London? It is
Yes.
in North London,
Yeah.
in Stevenage.
Yeah. North London. So, Dariel, if you want to even just drop me a message if you want more info on where to go. But I'll go back just so you can scan that. Actually, hold on. If you want to scan that QR code or take a screenshot, just if you're on your phone at the minute, you'll be able to click it afterwards, and it will tell you exactly where it's at. But as I say, give us a shout on the Instagram or the email as well if you want to, just if you need more info and whatnot. All right. Someone's asking if
Yeah,
they can't make next week, can they still
yeah,
access and get CPD? So they're always recorded, aren't they, Siobhan? As long as the speakers are happy, and it will be.
yeah.
Yeah.
Just give it about 7 to 10 days after the live webinar.
Yeah.
Lauren, thank you very much. Really appreciate that. Very interesting. Loads of too many thank yous to call them all out. Really appreciate it. I think you might have to come back and do that one again.
Yeah.
And thank you very much, everybody. Thank you, Lauren.
Definitely. Thank you all
And
for
we'll see
coming.
you all
Thank
next
you.
week. Bye now. Bye
Bye.
bye.
Bye.